everyone, and welcome to today's CPPC public lecture on understanding applied behavior analysis and clinical practice. My name is Lucia, and I will be moderating today's session. We are very pleased to have two speakers with us today, who is like Congyue and Harry, and they will be sharing their professional experiences and insights into applied behavior analysis, clinical practice, and career development pathways in the UK. And I would also like to thank everyone who helped organize and support today's event, which are our CPPCUK committee. The main organizer is Congyue and Yihan, and the poster design is Millie, and the survey and live session support is Aubrey. Okay, next slide. Today's session will be recorded, and the recording may be later uploaded to CPPC UK's YouTube channel and Bilibili channels. The views and experience shared today are based on speakers' personal experience and journey. They do not represent the official view of the NHS, their employers, university, or any organizations they work or studying in. Next slide, please. Yeah, so we will begin with a very short introduction and followed by speaker's presentation for roughly an hour. And then we'll go through to the Q&A session for half an hour. During the presentation, please feel free to submit your questions through Slido using the QR code on the slide. You're also very welcome to upload questions that you are interested in within Slido. Slido will automatically rank the questions based on the number of upvotes, and we will go through them in that order during the Q&A session as much as possible. Next slide, please. Okay, so I would like to briefly introduce our speakers in today's content overview. Our first speaker will be Congyue, who is a board-certified behavioral analyst working with the Community Learning Disability team at North East London Foundation Trust. And our second speaker will be Harry, who is a second-year trainee in the Doctorate program in Clinical Psychology at UEL. Today's session will mainly cover 4 areas, which are introduction to ABA, applications of ABA and career development pathways, and also the overview of NHS community learning disability teams. So without further ado, I will hand over to our 2 speakers. Thank you again.
Thank you. So first of all, just let's do a little bit of quick introduction of ourselves. First, my name is Congyue. I'm a board-certified behavior analyst, and also I'm registered with the UK Behavior Society for Behavior Analyst. I obtained my master's in psychology and behavior analysis, and currently I'm working within NHS service based in Community Learning Disability team in London. I am working with adults with learning disabilities and co-occurring mental health and neurodevelopmental conditions. I also received other trainings in acceptance and commitment therapy and relational frame theory. Those are my special interests as well. And now I'm going to pass it over to Harry for him to introduce himself.
Perfect. So my name's Harry. I'm a second-year UEL trainee clinical psychologist. And I'll be kind of talking about my role where I worked at the Learning Disabilities team, which was a 6-month placement between October 2025 and April 2026. So I've worked in the NHS for a few years now, but really it's kind of the experience of the training I'll be talking about because it's the most relevant. In this role, I kind of did some direct working and some indirect working. Which I'll explain more later when I'm talking about the clients. The sort of therapies that I use and are relevant to this are the more narrative, which is about language, systemic, which is about sort of family systems, wider systems, so groups of people essentially, and cognitive behavioral therapy as well. But I'll get into more depth on that later. But it really is the experience of the training. So I haven't done any additional training because there are requirements that you actually get the clinical psychology qualification first. But yeah, thank you very much.
Great, thanks, Harry. I just listed a few of the objectives of today's presentation. The first one, we would like to develop and establish a broader understanding of applied behavioral analysis and applications. So for those people who are already in this area and know ABA a lot or utilize it in their work, practical work, so this is not really for you, but if you're interested in knowing more about community learning disability team, then the second part will be for you. So not in-depth understanding today, we will help with broader understanding. And next, we're exploring career development pathways within ABA and understand the training and the professional route to becoming an analyst, particularly if you're based in the UK or would like to pursue in this area. Then I'm gonna have a very brief introduction on this. And then also, like Harry said, me and Harry are gonna share our personal experiences within CLDT team as a behavior analyst and, sorry, I forgot trainee there, trainee clinical psychologist. But you will be the clinical psychologist, Harry. So what is the ABA? The first one, when you see ABA here on the screen, what comes to you first? Or how you can relate it to ABA based on your experiences or your knowledge. I have a few examples there. Most often time we hear people saying ABA is a behavioral modification approach. Yes and no. Behavior modification, it was used in decades, years ago, I would say, and now we're not using this word anymore. And when it comes to ABA, people start thinking of animal behaviors. Yes and no again. Yes, it's rooted and started with animal behaviors and started in this ages ago. Ivan Pavlov is the well-known experiment in classical conditioning. That's where it started with. And autism intervention, a lot of times people start talking about ABA and saying, oh, ABA is only for autism. Yes and no, it is for autism and is used with autism population, but it's not only. And sometimes people start talking about rewarding good behaviors. Yes, part of it, not only. Early intervention, yes, is used and utilized in early intervention, particularly special needs education. Special education, yes, and so a lot of people talk about ABA, and the first one they will say, oh, it's used in SEND. But other than that, we have way more about ABA. So organizational behavioral management is OBM. Is used for improving employee performance, workplace safety, leadership, communication, and company culture in business organizational companies. That's based in ABA. Verbal behavior. So later we're going to talk about what behaviors are. One of the behavior we're talking about within ABA world is a verbal behavior in terms of language development. In the UK, if you're based in the UK, you probably heard a lot about positive behavior support, PBS. So PBS is a framework and guidance which is utilizing ABA as part of the behavior support plan, the PBS plan. And relational frame theory, if you heard about RFT, is so give an example what RFT is, simply saying, this slide is about RFT. So when you have ABA and how you develop and expand your network of your knowledge and verbal behavior. So RFT and verbal behavior, I would say they go hand in hand. Okay. Contextual behavioral analysis. Contextual behavior analysis, if you know ACT, this is rooted in contextual behavior analysis. And then later we're going to talk about applied behavior analysis. We mainly talk about contextual environmental context. So this is very, very similar to each other. And oh, sorry about that. Natural environment teaching. If you're in early intervention, you probably heard about this term a lot. And then in community learning disability team, which where I'm working now, is using a lot natural environment teaching when it comes to OT skill teaching and speech and language therapist language teaching. Sorry. Functional communication training, that's used in a lot of special needs settings. ABA schools, they use a lot of functional communication training, not only SALT. ABA talks a lot about it, particularly when it comes to behaviors of concern. So we need to look at the functions of behaviors and to teach appropriate behaviors to replace that behavior, the problematic behaviors. And skill-based teaching, training. So when we talk about behaviors, we'll not only talk about problem behaviors, we'll talk about skills. So that's, we use the skills to teach appropriate skills to replace that behavior of concerns. Okay, so not only, so I'm only listing a few of the things that would be talked about within ABA, but not limited. There are more, way more than this. Okay, so what is ABA? Now, before talking about ABA, we need to talk about what behaviors. So how you understand behavior. A lot of people talk about behavior, then what it is. You probably already have some examples. So what is behaviors? In ABA world, we say anything that a dead body cannot do is a behavior, which means everything people do is a behavior. Okay, that's including how people move, which means how people do things, and how people say, what people say, think, and feel. So we categorize into two groups. That's most of the time we use the term overt behaviors and covert behaviors. Okay, I specifically said address their verbal behaviors. I just don't want people to forget we do work with on the verbal behaviors, which is language development. So sometimes you hear people talking about internal and external behaviors instead of overt and covert behaviors. So all behaviors occurs within an environmental context that we already quickly mentioned in the earlier slides. We talk about environmental context. We put behavior in the environment. Without context, behaviors doesn't happen. Okay. ABA stands for Applied Behaviour Analysis. And there is the definition I took from the BACB. So later on, we're going to talk about the BACB. BACB is the leading organization for all the behavior analysts, board certified behavior analysts. So on the BACB website, it says ABA is a science based on the use of learning principles to improve lives. The practice of ABA focuses on assessing environmental influences on behavior, assessment-based intervention, and data-based decision-making. So there are three elements within ABA we mainly talk about. First of all, environmental influences on behavior. So we put behavior, this individual, in the environment, and we're not changing the behavior. Then what we do? We assessing the relation, the functional relation between the behavior and the environment, and then modifying the environment so that to influence the behaviors. So behavioral change is only an outcome of the modification in the environment. And then second element we'll talk about is assessment-based intervention. We do assessment and identify and analyze the functions of behaviors. And based on the functions, we design and develop a support plan. And then the third element, which is the most, I would say the most important element within ABA, is the data-based decision-making. We're not making decisions without data. Any, let's say, behavior support plan need to collect data, monitor data, and analyze data first. Based on your outcome of analyzing big data, you make decisions. Behavior analysis is characterized by functional analysis of the effects of behavior on the environment. So the same thing. Yeah, so very important elements there: environment and functional relations, and how they affect on the behaviors. So you probably heard a lot about the three-term contingencies. That's the basic unit of analysis, which include antecedent, behavior, and consequences. So what is an antecedent? Is anything or everything happens before the behavior occurs. Anything. When you're sitting in the room, anything happens in the immediate environment. Okay, behavior is the target behavior. Consequences are anything happen after the behavior occurs. So that's the sequence of the unit. And when we know the ABCs and we look at functional relations between the three terms, the first one is the antecedent and behaviors, and the second one is the relation between this behaviors and consequences. So when you're analyzing the behaviors, so antecedents is kind of the trigger or cause to the behaviors, and that can elicit or evoke the behaviors. And then later the consequence is maintaining the behaviors in the future, and that will have will influence the changes in the behaviors. Then we will say there are four types of behavior change, including positive reinforcement, negative reinforcement, positive punishment, and negative punishment. Don't worry, they're quite conceptual, but this is just telling you how the behavior changes. When we talk about reinforcement, it's increasing the behaviors. But when we talk about punishment, it's probably different from what you thought before. So punishment is decreasing the behavior in ABA world. Okay, so reinforcement, increasing behavior, and punishment, decreasing the behavior. And positive and negative, so that's very simple concepts. Positive, you're adding something into the environment. So positive reinforcement is adding something into that environment to increase the behaviors. On the contrary, negative reinforcement is withdraw and remove something from the environment to increase the behavior. Similar to the punishment procedure. Positive, adding something into the environment to decrease the behavior. Negative, withdraw and remove something from the environment to decrease behavior. Okay, so when you're talking about punishment, a lot of people relate it to very negatively, like a timeout. This kind of thing that is only one of the approaches we use within ABA. But timeout is not equivalent to punishment. Punishment is the change in behavior, which is decrease in behavior. So, and then we'll say behavior has a function when we analyze the functional relations. Functional analysis. Functional analysis to obtain information about the purposes or the functions a behavior serves for a person. So we analyze and identify the functions and to hypothesize about the relations among specific types of environmental events and behavior. So again, everything is about a functional relations between antecedent behavior and consequences. And then we identify the patterns in these behavioral changes, either reinforcement or punishment. That means increase and decrease in behaviors. Okay, what ABA looks like in everyday life. I am just giving you a very simple example. It's not limited. ABA concept can be utilized in very, very different ways and different behaviors. So, for example, feeling hungry. We're feeling hungry every day, and every people would feel hungry. And after feel the feeling of hunger, what do? You go into the kitchen and make toast. Okay, again, it's only one example, one behavior. So feeling hungry can actually trigger different behaviors. I'm going to give you one now, okay? You might go to shop to buy some food. You might go to cook rather than making just simple toast, okay? You might go to a restaurant to order food there and someone cook for you. So different behaviors, but the feeling, okay, is leading that behavior. So the feeling hunger to leading the behavior, going to the kitchen and making toast, and what happens after hunger goes away and the toast tastes good, you feel happy. And then let's talk about it in ABA language. Antecedent, feeling of hunger, behavior going to the kitchen and making hunger. I probably missed something. As a consequence, you are satisfied. Your needs is met. Okay, so when your needs is met, and that's to maintaining your behavior again. So in the future, when you feel hungry again, and you having the same behaviors and the same consequences. So we are looking at the pattern of behaviors. ABA can be used in different areas, and I'm listing a few of them. Not all. They're only the main you look at ABA in those areas. Is ASD support is very important, and the majority of people use ABA in ASD population, and education, clinical psychology, and mental health, organization, behavior management, OBM, we talked about earlier, parent and family training, speech and language development. Remember, we talked about verbal behavior. That's what it's for. Healthcare and rehabilitation, sports and fitness, sorry about that, gerontology, I hate that word, care for older adults, and animal training. Okay, so that's I would say commonly you will see ABA being used in these areas and fields. So, and then ABA in research. ABA in research, ABA has been studied and researched in this area. I probably should, and the last one is forensic. Actually, I should put this one in the previous slides. In the UK, we can talk about later on. So in the UK, in Scotland, there is a service having a behavior analyst who's working in a forensic setting. So ABA has been studied in autism and developmental disabilities, education, OBM, mental health and medicine, animal behavior, gerontology and aging, sports and performance psychology, behavioral economics, public health and community programs, technology and human-computer interaction, parenting and family training. If you're interested in any of this, please do find the paper. Very interesting. Actually, you know what? Just reminded me, the first article, if I'm not mistaken, there was one article in 1970s was studied ABA in mental health in an inpatient ward, which is very interesting. So, as I said, I'm regulated by the BCBA, and the BCBA has those subspecialty area. You can see that's already been listed in the previous slides. So that means BCBA is like a qualified behavior analyst. They're working in these areas in different countries. So next, behavior analyst in the UK. How ABA is used or by the behavior analyst in the UK, ABA has been utilized and applied in mainstream and special education, NHS and adult care services, governmental departments, looking at group changes such as increasing recycling, road safety, and so on, and industry helping with employees' motivation. What's this about? OBM, right? So in the UK, I have seen there are a lot of behavior analysts working in the OBM field. How to become behavior analyst? There are two organizations based on my experience, which are quite relevant. The first one is the leading organization, Behavior Analyst Certification Board, BCBA. That's my regulatory body, the main regulatory body as an international certificate. It's before 2025 December, it was still internationally certifying and recognizing the behavior analyst, but by start in January this year, this has been stopped. Currently only the people who are living in the US and a part of Canada can go for the search and exam. So if you're based in China or UK or anywhere else in the world, you can actually you can't pursue a BCBA title anymore unless you're moving to the US or some parts of the Canada. And another one is a local regulatory organization in the UK, which is the UK SBA, UK Society for Behaviour Analyst, is the only credential organization in the UK. Within SBA, there are 3 routes you can become a UK BA. I don't have any slides for the there are different levels within UK SBA, the same as in BACB. So just to quickly mention, there are different levels. One is the registered technician, behavior technician, which is the lowest level of in this field, and then is a assistant behavior analyst, and then a BCBA or UKBA, which is my level, and then the higher level is the BCBA-D or UKBA D in the UK. I'm only giving you one example. For route A, there is a requirement.
I'm sorry, Congyue. Do you mind turning off your camera? It's a little bit laggy.
Sure.
Thank you.
Is that better now?
Yes, it is. Thank you.
Perfect. So I'm not quite sure you heard everything I said earlier. Hope I don't want to repeat everything again. So requirement to become a UK BA, first of all, you need to have a master's degree in behavior analysis or a related field. And then also the university course need to be approved by the UK SBA and or ABAI. ABA is Applied Behaviour Analysis International, which is an international organization again based in the US. And of course, you need to complete the UK BA supervision and competence standards. So there's a difference between UK BA and BACB procedure. So UK SBA is only requiring competence, pass the competence checklist. However, in the US, the BACB will require you to sit in an exam. Once you pass the exam, and you will be certified. Of course, in addition to that, you need to fulfill all other requirements. And then once you have all the evidence and submit it, and they will attestation form that you need to complete it and submit it. Oops. There are 5 universities in the UK, of which the course has been approved by the ABAI or EKSBA, which are University of South Wales, Bangor, Kent, Queens and Ulster, based in Northern Ireland. So next, let's talk about Community Learning Disability Team. CLDT consists of psychiatry, psychology team, and OT team, SALT, speech and language therapy team, nursing, and those are within health team. And also we closely work alongside social care team, which is part of local authority and shared lives. And our clients aged 17.5 plus until end of life. And our clients primarily diagnosed with diagnosis of learning disability, or actually I could have added there, learning difficulties and other comorbidities. I would say 100% so far have not only learning disability. So other orders, family cares, day centers, supported living, and respite and other community services, which we all closely working with. Within our team, within psychology team, or within our CLDT team, there is a behavioral concern pathway. Behavioral concern, that means all the with so-called challenging behaviors, but we don't use this term anymore. Instead we use behavioral concerns. So I am the main person looking after this pathway and referrals coming for behavioral support. There is a flow chart I don't have here, but I simply just summarize the pathway with the 4 steps. First one, receive internal and external referrals, and then we conduct screening and initial assessment via MDT, multidisciplinary team, and case formulation and action plans, and then we design, implement, and monitor interventions, and then close the case. So very simple now. Working within CLDT as a behavior analyst, my role and my responsibilities here, not limited, okay? So screening and initial assessment, functional behavioral assessment, data collecting and analyzing, behavior support development, developing and records and report writing, staff care training, individual and group clinical work, MDT meetings, and other admin and caseload management, okay? So individual and group clinical work, some are in progress. Just mentioned that. CLDT psychology service, student placement, and volunteers. We do, like Harry will talk about his role later on as a trainee clinical psychologist within this team, but also I'm establishing a student placement for behavior specialist. That's my job title, okay? And also volunteers who will be closely working with me in this within this team. So the roles are facilitate in individual and group sessions and care and staff trainings, and some admin support. So because the students placement and voluntary placement are established by me, so they will be supervised by me. Some benefits, clearly, if you will be working with the NHS system and you will be working within MDT to experience some MDT approach and learning opportunities, and also if you very interested in behavior analysis, how behavior analysis utilized with adult population and in community setting, and this is the best opportunity for you. So this is very interesting. Before I finish, I just want to show you, because this highlights the importance of the need of dissemination, ongoing responsibilities for disseminating behavior analysis. You can see that, so this is coming from BCBA website. Because BCBA is the leading organization and based in the States, of course, United States have the most professionals in this field. And then let's look at United Kingdom, the UK. We have only 700 plus behavior analysts based in the UK, based in the UK. Whereas China has only 488. Let's think about population. Think about the how ABA could be utilized and applied, and then the population of people who are in need to have this kind of a support. And this is way more, not enough at all. Okay, so this is why I think the importance and urgent need for behavior analysts to disseminate our profession. 100% sure in the future, we definitely will have this field, this area and profession can be very beneficial to different people and population areas, professional areas. That's what I meant. And I'm going to hand over to Harry.
Thank you, Sonia. So I thought I'd start off with kind of beginning with my reflections coming into the placement, because I think with the training of clinical psychology, so being a trainee clinical psychologist, you actually don't get much choice where you're put because you have to meet competencies. And one of those competencies is a learning disability, but most people fit that competency in a different placement where they just work with one client who has it. So going into a learning disabilities placement is a bit different because it's a different way of working, which I'll come on to. There's not much experience available to a lot of people in the UK to work in a learning disabilities team, and I think that's a massive tragedy in a way. So I've had quite a different experience working in a community mental health team, working in inpatient wards, working with different age groups, so older adults, younger children, in different settings with different presenting symptoms or diagnoses. But when it comes to learning disabilities, oh, sorry, do you mind just muting? I think you've just joined and there's a bit of background noise. Thank you. So I've worked with quite a lot of different settings and different client groups, but when I found out in second year that I had this placement, we hadn't had any training on it yet or teaching on it because our second year includes that, but you start the placement quite early on. So I remember going into the team and feeling quite nervous because psychologists love to talk. It's very much a talking profession. I think a lot of people even call the psychology profession the talking therapies, which isn't quite accurate. But you're coming into a client group who have cognitive impairment. They might have communication difficulties. I think the vast majority of the clients have communication difficulties, which means the normal way of working is different. We like to ask questions like, where do you think that comes from? Or we like to make sure the client gets to the answer themselves. I found going into this placement that if you ask these clients very sort of strange questions, they might not understand what you mean. So if you ask them, where do you think that comes from? They might go, not sure. And that's not that they actually don't know, it's that you need to adapt to the way you're working with them. And I think there's a lot of adaptation that needs to happen with this client group. But I'll come on to that at the end of this reflection. I came into the team and it's very different the way they work as well. It's very team-based. Sonia mentioned all the different professions that are included in these people's lives. And it's because a learning disability is a lifelong diagnosis. So it's not like they're going to change that. And it means that they might have more difficulties later on. So they can actually end up being open to the team for quite a while. They might be open to psychiatry because they're on the medications. They might be open to OT because they want to learn some additional skills, maybe how to cook, things like that. They might be open to nursing because this client group also face a larger proportion of physical health difficulties that aren't addressed. I think there's things like constipation, a lot of dental pain, and fear of dentists as well because of the sensory experience. So there's a lot of input with a lot of professionals. In the other teams I've worked with, they've kind of been separated. Psychology sits on its own. And that's very odd because if you ever want anything from another professional, you have to refer to them. You have to send a referral off and go, I'm working with this person, please can you see them as well? And then they have to go through a referrals process that takes a while. They might reject it. They might refer them on to somewhere else. And you do have to refer within this team, but you can go and talk to them quickly. You can have a conversation. You can do a very quick referral, or we have a team meeting where everyone's present. And I think there's just a different approach to these people where previously I've had to fight more for them. I've had to advocate. But actually in the team I worked in, it was very much like oh, I can do this, or we'll do something about that. And it's very pleasant. It's actually a really nice experience to have that integrated team where it really feels like people are trying to support them. And like I said, there's a longer term working. And this meant that I worked with some clients my supervisor knew. My supervisor, the consultant clinical psychologist, had known these clients for decades. And it was really pleasant because she was like, "Oh, I've met them, and you might want to think about this, or their family are really nice and involved." And when I'd worked with them, I'd mention my supervisor, and they're like, "Oh, I love that person," and it just meant you're coming in with maybe a bit of knowledge you might not have had beforehand, and that's actually a really nice way of doing it. And I think when you work in other teams, they have a sort of set rule of kind of 12 sessions, which never feels enough. I don't think it is enough. But with this, there's a more relaxed, we want to help them, so let's see how it's going to be. And with the nature of 6-month placements, you typically have to close clients at the end and say, "I'm leaving, I'm sorry." But with this one, we turned around and went, "I think this person could carry on seeing the next trainee or even my supervisor." And it's really nice because you don't feel like you're almost abandoning them. So that's all a really pleasant experience. And I think I came in quite scared or anxious or worried because it was a bit different from my previous experience, and I didn't know how I was going to do things. I was very anxious on how to adapt my previous knowledge, but actually I felt that it was a really pleasant experience, and actually it was a lot easier than I expected. Not the work was easier, but the adaptations were easier. I think one of the adaptations I turned around was even saying, "Can I suggest maybe a few feelings you might have?" and made a list. And the client went from going, "I don't know," to everything to going, maybe. And we then honed in on those maybes and realized that actually they were the ones that he agreed with. He was just worried about what would happen if he said yes. But it's I think another reflection I had is the variety of work. So yes, they have a learning disability diagnosis on the whole, but that's not all they have. So they have the comorbidities, like Sonia was saying. So all of the variety. So it can be psychotic, it can be delusions, hallucinations, but it can also be things like depression, anxiety. I had one client who was scared of crossing the road, and that was a really big thing for him because he really liked walking. And then you have maybe some difficulties that affect this client group more. So that can be things like bereavement. So bereavement is always really tricky, but bereavement for this client group means something more because normally it's a bereavement of a family member, a parent, and the parent can be a carer for a long amount of time. And so not only are they losing a parent that they loved, but they're also losing someone who cared for them their entire life. It might also question, where are they going to live? So it's really you do very special work, very important work with this client group. And another one I was thinking of is you sometimes have some conversations that you would never normally have. I think I have talked about relationships and things like sex and things that are sort of more general conversations than something considered therapeutic, but they're very important with this client group because they're perceived a lot of time as vulnerable or more childlike by carers, care homes, family members who worry about them, and they kind of put a lot of boundaries in, but actually they have the right to live the life they want as long as it's safe. So you could talk a little bit about what a relationship is. You can talk a bit about online dating or having safe relationships. I think I've even talked about like what sex is to a client, which normally would make me very uncomfortable, but it was a very powerful conversation with them. So it really is a really wide job, and you're not just focusing on the therapy. And that's a really nice actual way of working that I enjoyed. But there is also the complexity of this client group as well. They do have a lot of them do have communication difficulties. A lot of other teams are involved, so you have to work with some care homes. You do have to maybe do some indirect working. So some of my work was direct, so with the client or with the client and a carer or a family member. And so you could talk to them However, sometimes that wasn't possible due to maybe they didn't want to engage, or maybe they struggled to understand some communication. And that meant you had to work indirectly. So you had to work with the care staff, you had to work with a family member. And I think that's more aligned with the sort of ABA side of it, of trying to shift behaviour as well. And I think me and Sonia have had some conversations about the differences between behaviour specialists and clinical psychology, and come to some realizations there's not many differences at times within this client setting. And I think I said that we as psychologists love to talk, and therefore we like to think we're different, but really we're both trying to achieve the same thing, and we do it in a similar way. But it's a really pleasant way of working, and you get a lot of ability to be flexible. So you adapt, and you can completely change something and just have a nice conversation. And I think there's a phrase I'm learned in my current placement about non-problem talk, which is really important. You don't want to go in and just talk about problems. You want to talk about strengths or hobbies. The best way I've built rapport with these clients, the way to build trust, is talking about what they enjoy doing, talking about things like cars or trips to Italy. And that has just been really nice, and in a way doesn't feel like work at times. But those are my reflections. It was a placement I went into quite worried, and I came out of it thinking, why aren't there more opportunities to work in this client setting? And also something I never considered before working in, and now it's something that I would be very happy to work in. But I'm now going to go on to two clients that I worked with to sort of give you some examples of the things I've just mentioned, and I think it's always better to have clients in mind when we do this. So the first client, thank you, Sonia, it was a Portuguese man in his 20s, and he was referred by the old clinical psychologist who happened to be leaving as I started. She had previously worked with him, and really we were wanting to sort of help this man with, he had some behaviours of concern when he was overwhelmed. So he would be quite aggressive, I think mostly directed towards his mum, who was also his primary carer. But it also meant that he might be quite aggressive in the community. And a typical response to that might have been, oh, well, just, restrain him or stop him doing that. But that's not really helpful for this, and that's not fair. So we were really trying to figure out what can we do to help him feel safer, because his communication wasn't very good. And an added sort of factor, a bit of context, is he actually was previously in a school that has had a massive investigation for the abuse they carried out onto the people in that school. So we came in with some theories about how he's trying to protect himself. So some people would see this behavior and think, oh, he's quite a strong, aggressive man. But actually it was, maybe he's quite vulnerable and worried about other people. And it's quite funny because I'm a tall man, and reading his notes, it was saying that he's quite intimidated by tall men. And I remember having to make sure that the person who contacted him mentioned that I'm quite tall. And just even that simple mention of me being tall meant that he wasn't aggressive to me at all. He knew what was going to happen, he felt safe, and it was great. This client, I worked alongside the occupational therapist, which was a really nice experience I've never had before. Normally you would refer to the OTs, occupational therapist, and they would work separately. And then this is an example of how this team works quite integratively, and we were like, oh, isn't it nice if we do it together and we can kind of use our expertise to make sure we're doing the job. So we both went to go and see the client and the mum, and what we did is we combined that knowledge to work with the mum as well on quite behavioural aspects, really trying to look at what can we do to him to make him feel more fulfilled in his life. So what is it he wants to do? How does he feel safer? How do we change the environment as well to make sure that he's not overwhelmed? And it was really nice because you learn more about the other professions as well. I've heard a lot about what OTs do, but to actually see it in person was really pleasant. And we did some direct work. So we would work with the mum and the client. And then this research intervention we did included also the OT working with the mum on some of the more systemic, so more family-based things like looking after the mum's own health. What does she do to make sure that she feels capable and not overwhelmed? And we agreed that it would be really nice if I worked with the client on those sessions. So I worked directly with the client while the OT worked with the mum on, I think it was 2 or 3 of the sessions. And so what I did with the client, sorry, is I did what's called the narrative tree of life. And this is essentially where you draw a tree. I've got the example here, so you don't need to remember this, but you draw out the tree and you label the tree with different parts of your identity. And narrative therapy is all about language. And the thing is, those people diagnosed with learning disabilities are some of the most stigmatized, restricted, and maybe mistreated client groups in society. IQ has its own issues, and IQ is used to diagnose learning disabilities. And essentially, they are almost taken out of the social life. And that's a lot of language used against them, a lot of derogatory terms in the past, a lot of terms we aren't allowed to use nowadays, which is a really big change, which is good. But it means that a lot of the time they've been told about the problems in their lives, and what they can't do, or what they're not allowed to do, or what they're being forced to do. So take your medication, you need to do these things no matter what. So they can have quite a negative self-view. And the whole point of the narrative tree of life is to actually explore maybe the positive aspects of their life, where they've come from, what they want to do, challenges they've overcome, important people in their lives. And it really is a sort of strength-based focus that allows them to reflect on their identity being, narrative therapy calls it rich and meaningful. It basically just means you're not just a problem, you are also an amazing person who's done all of these things, as well as facing some difficulties. Within that, we did this tree of life that he really enjoyed. We talked about things that he really valued. He loves to go to Portugal and Brazil. He's amazing memory. He's very, very good at drawing maps of things. He drew maps from memory for me. He loves trains and the underground. He loves to look at the weather. There were so many things that were just amazing, and so talented in some ways that just wasn't really highlighted because the behaviours of concern were the main issue people were saying. And then we also worked on some CBT stuff as well, where there's some anxiety around going outside and tall people. And so we did a really basic CBT intervention on that, which in this client group is more behavioural than it is cognitive, because of the communication difficulties and language, which really worked well. He ended up going out into the community a lot more, and not being as nervous. And there was a big reflection, me and the OT afterwards, about how great working like this was, and how at times we would go, oh, you know better about this than me, or they'd ask a question and one of us would answer it. And the family felt really supported, and the client really liked us in the end. And the OT is going to carry on working with them to really learn some independent life skills like cooking, because that was another thing that came up that he was really good at and wanted to do more. But yeah, this is an example of that sort of more MDT joint working that was really pleasant. And I think Sonia even mentioned to me that the OT has now gone to about the next trainee going, can I get her to be included in a client session as well? So it really highlights how it was a great experience for the client and the family, but also for the professionals themselves to not feel they're working alone, and they can really harness each other's knowledge. Next slide, please, Sonia. So there are pictures for this that will come after this slide, so don't worry. The next client I worked with was an individual. It was just me working with them, and he had been open to the team for over 10 years. So my supervisor knew him and the family really well. He's a 50s, he's a male in his 50s, and he has a diagnosis of Down syndrome and a learning disability. They don't have to be together, but he did have a diagnosis of both. I met him in my first week, actually, with my supervisor, and we agreed that it would be a really nice piece of work. So I was working with the client and the sister. The sister was the primary carer of this man, and he lived with the sister. And what he came presenting with was essentially trauma. That it was an incident in the community. I think it was over 10 years ago. And he'd had trauma-focused therapy with my supervisor. But it was very interesting because it come up, it was preoccupying him. I remember we asked the client, oh, does he want to say anything to us with his sister not present? And he was like, yeah, actually I do. And then he remembered this event that had happened over 10 years ago. But to him, it was a recent event. It was a really recent event that was stuck in his mind. It wasn't that he had flashbacks or any sort of re-experiencing. It didn't feel like it was happening in the present moment. It was more the way his memory worked is it felt like a really recent memory, and it really bothered him. And so we agreed that we can talk about this in a bit more depth, which he wanted to do. And I remember we asked him, do you think psychology would be helpful? And he said, yeah, it will be tough though. And I found that was a really honest answer. And I think at times you get a lot of honesty from this client group, which is quite refreshing as well. And we were like, yeah, it could be really challenging, and that's okay as well. And I remember I started working with the sister and the client, and he turned around to me and said he didn't want to talk about bad things. He didn't want to talk about the bad memory at all. He wants to focus on the positive. And I remember thinking, okay, normally with trauma, you want to talk about the trauma and you want to then talk about the wider context. But he said very clearly, I don't want to talk about the bad things. So I was like, okay, let's figure out what we could talk about. And we really agreed to talk about the positive things, because it felt to him, because of his memory, that the only thing happening recently was this bad memory. And we went, you've had a great life. Let's focus on these events of your life. And so we agreed to do a narrative timeline, which is essentially where you go from the start of his life and you try to remember the big events. And this up until the present moment, not all the events, because that would take way too long. And a lot of the time you kind of do it with pebbles and flowers, or another equivalent where you put the bad moments, the bad memories, as pebbles and the good ones as flowers. That's the sort of more typical way of doing it. But we did it a bit of a different way, which I'll go through when I show you afterwards, because again, it's all about adaptations. But I ended up also doing a dementia assessment with this client, because during the sessions, it came out that he, again, had a really sharp memory, really could remember people's faces. He went up to the receptionist who he hadn't seen in 7 years and was like, I know you. I've seen you in this place. It's incredible. It's a really sharp memory. But in some ways, he ended up having some memory difficulties with the local environment. He got lost, and that's a new incident for him. And he is over the age of 50 with a diagnosis of Down syndrome. They are an at-risk group of dementia. And we have a dementia pathway where we are trying to do what we're meant to do, the BPS sort of recommended screening and sort of yearly assessments. And the sister raised concerns. So we agreed to do that as well, because he trusted me, and he understood what it was for, which was really nice, because I think it can be really scary doing a dementia assessment. But it was a really pleasant experience for the sister, him, and myself. And then before I go on to the narrative timeline, I just want to say that I think this client meeting him and his sister was amazing. They were lovely people. They'd suffered quite a lot in their lives, but they were some of the kindest people ever. They ended up even bringing me a cake to one of the sessions, which isn't why I liked them. I liked them besides that, but it's it's quite nice to work with this client group where they are mistreated and restricted, and yet you can have such positive experiences with them and reflect on that. And I remember they rephrased disabled to differently abled. So he was capable of doing things, he just had to do it his own way. And that's a really nice way of reframing it. And the reason I tell you this is because a lot of the time psychology work can be quite sort of focused on the negatives, on the problems. But it was amazing to sort of reflect on, actually he's conquered so much in his life. He's had great experiences. He's really dealt with the hand he was given, and him and his sister just cared for each other so strongly. And in the sessions, he would turn around and go, "I love my sister. She's amazing. I couldn't have had anyone better." And she would think that he's also helped her deal with so much in their lives as well. So I think this sort of work, you can work with such complexity. You can have to problem solve and adapt, but you can also have such amazing sessions where you genuinely feel quite happy and pleasant. And yeah, so I'll just carry on talking while it's happening. So yeah, it was a really nice experience to work with all my clients, actually, because it's such varied work. You do absolutely anything, and also you're working with maybe one of the most disadvantaged groups, and it's even the sort of non-problem talk, even sort of talking about the hobbies and things, is so impactful, that the only thing we sort of talked about was the shame that it was only 6 months. The 6-month placement is quite quick, so it does go quite quickly, and then you're left thinking, oh, I would have enjoyed to do more. So this is the narrative timeline we completed. They gave me permission to use this for any training purposes, and the like. So I think with learning disabilities, it's important to try and, if they're capable, try and get them as involved as possible, because they are a client group that people will do things for them, and that really just exacerbates that lack of control they can experience. So we drew a timeline of his life and the main events, and it started off even just talking about his childhood and how he used to ride the bike, and then it went on to a trip he did where he ended up doing such amazing experiences of barbecues. He did some climbing. He went on a boat, and it's all when he's quite young. And then he's got his family member who was born, and that was just a really important event for him as well. And it's someone who now goes traveling with him all the time. So it was really nice for him to remember all of these things. And then we started talking about, like, okay, what's important to him now? And he went to a trip to Paris with his sister, and he got the Eurostar there, and that was great. It shows that him being able to do all of these things. And then we talked about how he's a really big photographer. He loves photography. He's really passionate about it. And so we drew that in, and he wrote that I like taking photos of trees with my camera. And then he's done sort of other drawings here that I think I'm a bit less able to read, but I know it says he likes to go for coffee, and I think that's about the food he enjoys to eat as well. So I've zoomed in for these, but this is sort of the different rows are a chronological order of the things he enjoyed doing. So I like going for coffee. My mum did some. It made my mum. It made me happy. So it's just really impactful events for him. And what you might notice is I didn't include any negative events, which is normal in a narrative timeline, but I didn't do that because he can't read. Even writing, he can copy letters, but it's more for his sister to say what it is to him. But we agreed that if we wrote negative events in, he would ask his sister, what is that? And then that would make his sister have to tell him about these negative events, which might actually be quite distressing for him, especially because he didn't want to talk about any bad things. So we agreed to just include the positive events. And so whenever he thinks of maybe the trauma, the negative events, he can just read this and remember that, yes, he has suffered, but also he's had a lot of really nice things in his life as well. And it really fits that differently abled that they connected with. But that's all for my experience and reflections on working the CLDT. I'd recommend everyone tries it at the very least. It was something I never thought about beforehand, but it's great. And try and get a lovely team to work with, because it was quite a nice team for me with Sonia and co.
Thanks very much, Harry.